Welcome back to Hematologic Malignancies, a summit update on treatment advances presented by Albert Einstein College of Medicine, Yeshiva University at OMED Live. You are tuned into the final live session of today's program entitled Therapeutic Decision-Making in Chronic Lymphocytic Leukemia with Dr. Kanti Rai. In case you're just joining us, my name is Dr. Peter Martin, and I'm an assistant professor of medicine in the Division of Hematology Oncology at Weill Cornell Medical College. Today's session is a live, interactive program that allows us to take questions in real time throughout the presentation. I encourage you to send us your questions anytime during the program through the box in the lower left-hand side of your screen. I'd now like to introduce Dr. Kanti Rai, Professor of Medicine and Molecular Medicine at Hofstra North Shore LIJ School of Medicine. He's on the forefront of research examining the natural history of CLL and is also involved in clinical trials of investigational CLL therapies. Welcome, Dr. Rai.
Thank you, Peter. It's a pleasure to be here. And I have been assigned the topic called Therapeutic Decision-Making in Chronic Lymphocytic Leukemia. And in the next half an hour, 40 minutes, I will like to share with you what changes have taken place in the last couple of years about how we approach treatment of a newly diagnosed patient with chronic lymphocytic leukemia, as well as previously treated relapsed refractory CLL patients. As many of us recognize that the treatment management decisions have gone through rather serious changes in the last several years. For a long time, we were very comfortable in treating CLL because, unfortunately, we had, relatively speaking, fewer choices. We had chlorambucil, we had cyclophosphamide, and then came fludarabine, and finally appeared rituximab. And combination of those agents step by step resulted in progressive improvement in the outlook of patients with CLL. However, in the last few years, several new exciting, promising drugs have appeared on the scene, as well as important progress has been made in understanding the natural history, molecular biology of this disease, which have enabled us to make significantly more rational, almost individualized decisions in patients. Now, how to make management decisions in CLL require us to think about each patient, whether the patient is with B symptoms, the symptoms being that we all recognize in all lymphomas and CLL, that weight loss of a significant nature without trying, increasing fatigue, drenching night sweats, frequency of infections. If any or all of those symptoms are present, then our approach to treatment will be drastically different as compared to those people who are completely free of those symptoms. In the last 10 years or so, we have increasingly recognized the importance of age. CLL is a disease of the elderly population. The median age at diagnosis is relatively high, 65 or even 68. And when the people are elderly, they come with the baggage of comorbidities, heart disease, lung disease, diabetes, arthritis, which reduces their mobility and ability to come to the clinic at frequent intervals. And previously we disregarded elderly with comorbidities. And when we think about historically, when Dr. Michael Keating first came out with the FCR regimen, he explained to us that in the frontline treatment where he had placed 300 or maybe more than 300 patients, he unfortunately had to exclude elderly people with comorbidities because those are the people who cannot tolerate serious myelotoxic chemotherapy regimens. But at the same time, unfortunately, CLL, as I said before, is a disease of the elderly people. And if you exclude elderly with or without comorbidities, then we are excluding a significant majority of patients in offering treatment regimens. So that problem is now gradually being handled, recognized, and in the process of being resolved. We also now have a much more precise way of diagnosing CLL as compared to just 10-15 years earlier, because now with the finer development of international workshop on CLL recommendations about diagnosis and methods of response evaluation published about 5 years ago in Blood, they have further improved upon the original descriptions provided by NCI working group led by Dr. Bruce Chesson of 1996 paper. And the precise diagnosis requires that we have evidence of B cells being in excess of 5,000 per cubic millimeter in patients on whom we want to make a diagnosis of CLL, that flow cytometry shows us a much more precise combination of phenotypic features, namely CD5 positive on B cells, that is CD19 and CD20 positive, along with CD23 positivity in the presence of either kappa or lambda light chain expression. So that diagnosis, with now our ability to distinguish deciding about treatment, whether the patient comes with symptoms or free of symptoms, and the clinical stage. The old-fashioned clinical stage, in whether from the Binet criteria or the criteria proposed by us, divided all CLL patients into 3 broad categories: low stage or early stage, early or low risk category, high risk category, and in between the intermediate risk categories. But we recognize that those stratifications were helpful in dividing groups of patients into risk categories. But when faced with an actual individual patient, those staging criteria somehow failed us in many instances. And now we have additional factors such as status of mutation.